Deep inside the palate, a heavy stainless steel jack screw locks into place. Under immense tension, it clicks open, a fraction of a millimeter at a time. It is a heavy piece of hardware deployed to solve a distinct anatomical flaw, an upper jaw that has grown too narrow to properly accommodate the skull. This clinical photograph shows the visible result, a severe posterior crossbite, where the upper teeth are physically trapped inside the perimeter of the lower teeth. Standard orthodontics cannot fix a deficiency this severe. Braces use light, continuous forces to slowly guide teeth through existing bone. To fix a completely constricted arch, you need a different protocol entirely. You have to bypass the teeth and manipulate the bone itself. This is rapid maxillary expansion, a skeletal, dentofacial orthopedic intervention that targets the underlying bone rather than the teeth. Once activated, the appliance generates extreme mechanical loads, pushing outward from the center of the palate with 10 to 20 pounds of transverse force. These vectors are deliberately non-physiologic. They are calculated to completely overwhelm the body's normal adaptive systems. The objective is a controlled physical trauma. The device is engineered to literally fracture the upper jaw apart before the skull finishes solidifying. To achieve this separation, the outward force targets a specific structural seam running down the roof of the mouth. This is the mid-palatal suture, the anatomical junction where the intermaxillary and interpalatine bones meet. For the appliance to split the jaw, this suture must remain unossified. If the bones have completely fused, the procedure fails. Determining if that biological window is open is highly unpredictable in human development. Normally, transverse growth of this suture stops around age 16 in girls and 18 in boys. But actual ossification, when the bones permanently lock, spans a massive, unpredictable window from 15 to 27 years of age, entirely obscuring the standard timeline. Because of this overlap, attempting to blindly force an expansion based purely on a patient's chronological age is incredibly dangerous. Clinicians need absolute biological clearance. They have to look inside the skull to verify the seam is open before loading the appliance. This pre-treatment occlusal radiograph provides that exact visual proof. The faint, dark vertical line running down the center confirms the mid-palatal suture has not yet fused. Chronological age tells you almost nothing. Visual confirmation of that dark line is the only definitive green light to trigger the expansion forces. Once cleared, the jack screw is activated, initiating a fast mechanical sequence. The appliance is expanded by 0.2 to 0.5 millimeters every single day. This rate is critical. It completely outpaces the osteoclasts, the cells responsible for resorbing bone during standard tooth movement. The biology simply cannot keep up. The molars and premolars banded to the appliance act merely as handles, transmitting the massive outward pressure directly to the bone. As the screw turns, mechanical stress shoots past the teeth and slams into the periodontal ligament surrounding the roots. The outward force violently compresses the periodontal space. With the ligament crushed, force transfers into the alveolar bone. The bone physically warps and bends outward, causing the anchored molar to tilt aggressively on its axis, a reaction known as buccal tipping. Before the skull ever separates, the localized dental structures and their bony housings are forced to bend to their absolute physical limits. Eventually, the alveolar structures reach a tipping point, yielding no further. The massive pressure has nowhere left to go, but straight into the midface. This is the exact moment the mid-palatal suture fractures, violently pulling the two halves of the upper jaw apart. You might expect the resulting gap to be a perfectly uniform, parallel corridor separating the palate, but the surrounding cranial architecture fights back. Deep inside the skull, the sphenoid and zygomatic bones act as massive structural buttresses. These rigid bones actively resist the transverse expansion, creating a severe drag on the posterior end of the maxilla. This illustration demonstrates the outcome. The resistance forces the suture to open in a distinct fan-shaped split, widest at the front teeth and narrowing significantly toward the back of the palate. The fracture is equally uneven vertically. The gap opens widest inside the oral cavity, progressively pinching closed as it moves upward toward the nose. The expansion creates a complex three-dimensional wedge driven deeply into the face, heavily dictated by the surrounding skull fighting the movement. This internal fracture immediately triggers a highly visible external change. A rapidly expanding gap, known as a midline diastema, suddenly appears straight between the two upper central incisors. The gap is striking, but it is temporary. Within 3 to 5 months, transseptal fiber traction pulls the teeth back together, closing the space. While the front teeth separate, the outward forces exact an involuntary toll on the lower jaw. As the upper anchor molars are tipped outward, they effectively extrude downward, changing how the upper and lower teeth meet. This slight extrusion physically forces the mandible to swing downward and backward, hinging the jaw open. Because of this rotation, the procedure is highly contraindicated for patients with steep mandibular angles, often called vertical growers, as it elongates an already long lower face. The structural shift extends upward too. As the palatal shelves separate, the outer lateral walls of the nasal cavity are pulled outward, widening the inferior aspect of the airway. This structural widening translates to a direct physiological effect. It drops nasal airflow resistance by 45 to 60%. The expansion forces bypass dental boundaries, shifting lower jaw posture and increasing total upper airway volume. When the jack screw reaches its target width, the active turning stops. But the clinical danger is now at its peak. You cannot rely on the midline diastema to measure success. The visible space between the teeth only accounts for about half of the total jack screw separation. To measure the true skeletal expansion, clinicians rely on post-treatment occlusal radiographs like this one. It reveals a massive, dark structural void running straight down the center of the separated maxilla. In this state, the maxilla is extremely vulnerable. The separated halves are unstable, and the stretched soft tissues are desperate to pull them back inward. To prevent collapse, the appliance must be locked tight. It is often immobilized with cold cure acrylic, holding the skull exactly in place for 3 to 6 months. This extended retention phase acts as a holding pen for an invisible biological race. Deep inside the fracture, bone-building cells called osteoblasts rush into the empty space, weaving a matrix of new bone across the void. If the hardware is removed prematurely, the soft tissue tension will instantly crush that fragile matrix before the new bone has a chance to calcify. Arch expansion is a process of engineering a structural void and maintaining it until new bone matrix calcifies, securing a permanent change in the patient's skeletal architecture.